Welcome all, and as you see by the program here, it's called Advocacy in a Health Crisis. And my name is Mark Ash, and I am proud to be a member of the Prince George's Senior Provider Network. I am also proud to be a member, as I just mentioned, of the Dementia Friendly Action Committee for North County and Prince George's County. And we're one of the only counties in Maryland that's really truly working together as a team to come up with ways to educate, inform, and help our residents do better in dealing with things like dementia and other illnesses. And part of that is creating awareness, education, and having informational programs like this. So this program is called Advocacy in a Health Crisis. And as I was telling Crystal, this program was actually born in the city of Greenbelt about 5 years ago. I was attending the Greenbelt Health Fair with an elder law attorney she and I were sharing a table. And a woman came up to us and brought up the term advocacy. And this woman that we started to talk with, her name is Helen Barnes. Some of you may know her in this community. Unfortunately, she passed a couple of years ago. But Helen was a geropsych nurse. So she sat down with us, and we put together this program, the format of this program. And the idea of this program is that the majority of people don't understand the point of advocacy or how things work when there's a health crisis. So our aim is to educate and inform, share good information, and that's why I want you to interact, because I want it to be something that you're getting something from. There's no test at the end of it, and if there was, it would be an open book test anyway. But again, my name's Mark Ash with Rated Home, and we'll get rolling with Advocacy in a Health Crisis. So what we're going to do is we're going to cover, what we did is create hello young lady, come right in. The program is going to be at one of these empty seats if you'd like. If you'd like to help yourself to a snack or refreshments beforehand, please do.
Okay, thank you.
And then come on in. My name's Mark. Welcome. So what we've done to convey this information, we created a case study so we could present this information. I want to point out this is all fictitious information. This is not a person that we know. We would never share a person's private health information. So we only are using a person's name and information to convey the points that we're making. Okay? So in the first part, we're going to meet Sally Smith, who is how we're going to present our issues. We're going to talk about legal issues, a real-world perspective, and then resources that may be available to help in this situation. This says question and answer period, but I want you to feel free to ask questions as we go along. So just a little bit about me. I don't have to read it from there, but my name's Mark Ash, and I am with an agency called Rated Home. We are a licensed home care agency. We've been serving this community for over 16 years. I've been with Rated Home for more than 7 years. And I've been a part of the Prince George's Senior Provider Network for 10 years. I've worked in skilled nursing as an admission director at a skilled nursing center. I've also worked in adult daycare. So I've been in healthcare almost 20 years, coming on 20 years almost. And I've worked in adult daycare, skilled nursing, and non-medical home care. I was raised, just to let you know, and I've seen this firsthand, I was raised in a nursing home in Baltimore. My grandmother ran a kitchen at an all-Jewish nursing home in Baltimore. My grandfather started a synagogue at the nursing home so the residents could have religious services. So I was born in 1964, and I had been going there all my life until about 2 years ago when it changed ownership. So I have seen firsthand when people go into a nursing home, and in the 60s, the standard of care was quite different than it is now. I never want to see anybody in that environment. And that's why I do programs like this. Because I want everybody to plan, to think ahead, and to have some of these relevant conversations that we're going to talk about. I'm also part of the Speakers Bureau for the Prince George's Senior Provider Network. So if any of you didn't know, the Prince George's Senior Provider Network has a listing where there's different speakers on different topics. So if you're part of a group, part of a church group, a religious group, a community group, whatever it is, and you want to have speakers there that just want to speak on topics that you could benefit from, Prince George's Senior Provider Network Speakers Bureau. Oh, no. Sorry about that. So, this is Sally Smith. For the purpose of our presentation, we're going to discuss these points through Sally Smith. She is a 76-year-old woman. She's a widow of a Korean War veteran. Come right in, please. There's a seat up front here if you like. Okay. The program's up here if you need. If you'd like to grab a refreshment, go ahead. So Sally is a 76-year-old woman. She's a widow of a Korean War veteran. She's a mother of 3 and a grandmother. She has Medicare Part A and Part B, and she also has supplemental health insurance. She was brought to the emergency room by her daughter after being found wandering and confused. She presents with symptoms of confusion, low-grade fever, decreased urinary output, probably caused by dehydration. She also has a couple of wounds in her private areas due to poor hygiene. So this is typical of someone who has advancing dementia. So this particular case study was designed specifically to address when we're working with someone that has dementia. So who is Sally's advocate? If Sally understands, clear of mind, what is going on, and Sally can make what is called informed consent. In other words, she understands when a physician or a medical person says, this is what we're treating you for, and this is the treatment that we're going to do. If Sally is in her right mind and can give informed consent, then she can allow that medical staff to continue with a medical treatment accordingly. So when a person has advancing dementia, are they in the mind to give informed consent? Everyone's shaking their head no. Not likely. They're not likely at all. So in this case, if she cannot understand or vocalize, if she cannot understand the treatment that's required or vocalize what her wishes are as it relates to that treatment, then it's best for her to have an advocate. If she is able to give informed consent, she's considered conscious mind, she's able to do that. If she can't speak for herself, doesn't understand the process or what's going on, she's considered incapacitated. She's not in the capacity to make decisions for herself. Now, we don't know when this is going to happen. None of us do. So it's important that you hear some of the things that I'm going to tell you as we go through this program, because planning for this can help all of us. Every single one of us would be affected by dementia, or if not dementia, so put another health issue in there, and some of these points are going to be very relevant. So if Sally cannot speak for herself, a person named in her healthcare power of attorney could speak for her. Her healthcare power of attorney. So hopefully Sally has put paperwork in place and has assigned someone to be her healthcare power of attorney. And we're going to talk about what that means in just a moment. Also, Sally could have named someone in her advance directive or living will. Your advance directive or living will, we're going to talk about that in detail in a moment. But that talks about the medical treatments and things that you would wish for yourself if anything, God forbid, ever happened. Or, in this case, if Sally has advancing dementia and they have she has no family around, she could be a ward of the state or a guardian and have a guardian of the person or a surrogate speaking for her. So these situations, though, should be clarified before a person develops dementia or before a person has an illness. And that's why, one of the reasons why we do programs like this, so we can talk about it. So Sally has rights that need to be protected. She has legal rights to protect her person and property. She has medical rights. We each have the right to be treated according to the way we would want to be treated. So there is a document or a series of documents which we can talk about, which tells what sort of medical treatments we would want. And then she has personal rights, of course, her dignity, her security, her safety. So if we do not plan for this type of crisis, this could go very badly for Sally. Does everybody agree? Does anyone ever know someone that doesn't have to be a family member, but someone you know, or maybe someone in your community who's been affected like this, where they've gone to the hospital?
Sure.
You've had situations you've heard about? It's happening more and more frequently every day. For some reason, Greenbelt has become a mecca of people just wandering from miles away. They even recently, I understand that there was a lady that made it from here, from New York, that got off the bus that had no purpose or didn't know why she was coming here. So it's important to have all these things ironed out. So what documents do we need and why? And this slide is, of course, in there. So let's go through. I brought up healthcare power of attorney. It's a legal document which names the person, the agent, who will stand in your shoes as the principal decision maker if you can no longer speak for yourself, or if you've given them just a temporary, like if you're having an operation and you want somebody to be your healthcare power of attorney just for the point of that operation, they can make healthcare decisions if you authorize them to do so. So that person could be your advocate. They're able to make healthcare decisions for you if you can't speak for yourself. And it's not limited to end-of-life decisions. It could be episodic or it could be ongoing. I recommend having a healthcare power of attorney and having a backup. Okay? And you can name them in the document your healthcare power of attorney. You do not need to see an attorney to get some of these documents, but you may want to have these documents certified, notarized, or something of that nature to make them valid and more protect you in a better way. So that's your healthcare power of attorney. Yes, ma'am.
If they're not certified, will the hospital or whomever you're going to, will they accept it because it's not certified?
Yes, you should, whenever you have a document that you create like that, you should get a couple of witnesses and sign and date and all those things to make it official. But if you have it notarized, that especially takes it to the next level. And if you have it drawn up by an attorney, that especially takes it to the next level. But if you are carrying the documents with you, then they should be recognized as such, yes. Yes, ma'am.
But it's better to have it, if possible, to have it notarized.
Yes, to protect all parties. Yes, ma'am. The second document is called your advanced directive or living will. There's also other names for this. In Maryland, we have the MOLST form, medical order for life-sustaining treatments. We have the 5 wishes form. Has anyone ever heard of any of these forms? Does anyone want to volunteer if they filled out their advanced directive or living will? What that does is tells the medical team what treatments you would allow. We all have different wishes and preferences. Everyone in here is over 21. We've all earned the right to be treated in the way we wish. Some of us have religious feelings about having a tube down our throat or being hooked up to machinery or whatever it is. But if we don't spell those things out in a legal document, if we go to a hospital, they're going to do every kind of treatment that they believe is pertinent or necessary. So if those are not your wishes to have all those types of treatments, then you must spell them out in your advance directive or living will. And it is best to have that notarized. Absolutely. Can you change that? Yes. 10 years ago, if you wrote your advance directive and you believed one way, and now you believe a different way or believe in a different type of treatment, you can change your advance directive or living will. Just make sure you have it notarized or certified by an attorney and protect yourself. It's about protecting yourself, but also, I want to point out, and we're going to have this, I'm going to bring up this point a couple of different times. It is important before you are incapacitated, before you are sick, it is important to have a discussion with your family and any relevant people in your life of how you would want to be treated if you were sick, if you did develop dementia, if you did have a health crisis. I encourage every one of you to sit down with your family and relevant loved ones or whomever and have this discussion and then put all of your wishes on paper. What it does is it sets your family up for success. It sets you up for outcomes that you want, and it unburdens your family members. It unburdens your family members. Because if you have 3 children, little Johnny might believe mom wants to be treated this way. Deborah believes mom wants to be treated this way. And the next child believes mom wants to be treated this way. But that none of them may be the way that you actually wish to be treated. So if you have the discussion with your family and then put those wishes on paper, you are setting yourself up for success to be treated the way you would wish, and you're unburdening your family. In my family, my father had 2 cousins, 2 brothers. They were my father's cousins. They fought at their mother's funeral over what they thought her wishes were, and they excommunicated each other for 30 years. Is that worth it? It's never worth it. So if you have these discussions while you're in your right mind, while you're able, you protect yourself and your wishes, and you see that the family carries out what you want. And when you put it on paper in your advance directive or living will and some of these other documents, you protect your wishes. And when you carry it with you to the hospital, you protect your wishes even further. How many of you know where you should have relevant documents like this if an EMT picks you up? Yes, ma'am.
I have mine on the back of my front door as they come in.
Okay.
Taped up there with.
Great place for it.
Yeah.
Because they have to leave out the front door, right? That's a great place for it. EMTs, emergency medical staff, know to check on your refrigerator. So you can put them in a little plastic sleeve and tape them or Velcro them or whatever to your refrigerator. If you have prescriptions, I recommend carrying your prescription, a list of your prescriptions with you on your person. On your person. And then specifically,
blood type there as well.
Blood type, absolutely. And also if you have any allergies to medication. Because you don't want them to give you a medication that could kill you. Right? So you protect yourself by planning. That's why you come to programs like this, and hopefully you'll take some of this to heart if you haven't already. Okay? And the next form that you should have is a HIPAA authorization form. We all know that the Health Information Portability Act protects our protected health information. We all have right to our private health information, and the hospital doesn't have to share your your treatment or your information with anybody unless they're authorized. You sign a HIPAA form authorizing the hospital to talk. If you have 3 children, authorize each child if you want them to be a part of your medical treatment. If you want to appoint one of your children as your advocate or the person, your healthcare power of attorney, you can do so. And you can also appoint a backup in the event that the first child or the first person you assign can't be there. It could be a spouse or whatever, but maybe they're not there. Maybe it's an emergency. Maybe things happen. So you want to have an advocate and a backup that are willing to carry out your wishes. I did this presentation a few years ago in Bowie, and a woman raised her hand. She said, I have all of these documents in place. Everything was done by my attorney. I've sat down with, she said, I have 1 adult child. I've discussed my wishes with my 1 adult child, and he is not willing to carry out my wishes. So we suggested that she hire, or either first have a friend or someone who she's close with, assign that person as her advocate, or she could hire a professional advocate like an attorney, or there are firms that just work as healthcare advocates and just do that work. But you've got to make sure that everyone is aware of what your wishes are. And that's why with dementia, this becomes extremely critical. You're planning in advance before a person develops dementia, because you're protecting yourself and your assets. If you have dementia, that's not the time to decide what children are going to get what and what children are going to decide what. That's the worst time. A person with dementia shouldn't be making those decisions. Those decisions should already be made in advance. And we should always have that discussion in advance. So is everybody comfortable with these documents? Not that you're comfortable with them, but you understand where we're going with them.
Excuse me.
Yes.
I think an important thing too is to realize that at the time of the death, the healthcare advocacy form no longer applies. So wishes about the remains, etc., need to be handled separately.
Well, that is true, and that's where your advanced directives should spell out how you would want to be treated. I have to put my wishes on paper, for example. My wife and I both want to be cremated. But my Jewish mother thinks that I want a Jewish burial and all these other things. And in fact, I was at a funeral with my mother a few weeks ago, and I said, Mom, I don't want any of this. And she said, not as long as I'm alive. I said, those are not your wishes, these are my wishes. And so I have to make sure that I put that on paper. You bring up an excellent point. You have to make sure you put that on papers that those wishes are carried out. And it's important to plan in advance of these types of things. And we all know, unfortunately, it's a bit of a crazy world. We have people walking into places with guns. We have dementia coming at different ages now. We have a number of different things. It's better to plan sooner than later. You can always change it down the road, but if you put a plan in place, you'll have a plan in place. You protect yourself and your family members. So we discussed that Sally, in this case, has Medicare Part A and Part B. Medicare Part A is going to cover Sally's inpatient care at the hospital. If Sally needs to go to a skilled nursing or rehabilitation center, that is going to be covered partially. It's going to be covered 100% for days 1 through 20, and day 21 through day 100, it's going to be covered at 80%. It's going to cover home health and hospice. And then Part B is going to cover some of the medical treatments that Sally may receive in the hospital, and it also covers some preventative health measures.
Is the 152 the max?
No, as a matter of fact, that's low now. The 150, so right now, the average, the 20% average that you pay your copay in the nursing home is around $160 a day. around 160. So when this program is done, it was a little bit lower. So your average stay in a nursing home is about $600 a day. So if it looks like you're going to be in there for more than 20 days, sometimes that skilled nursing center, and we're going to get to this, that skilled nursing center might ask you for a month in advance, which is your copay, $160 a day times 30, $18,000. Does anybody have $18,000 laying around right now? I was going to ask to borrow $10 for lunch, but it's okay. I won't. So, this is another thing that's critical as well. When your loved one goes into the hospital, you want to find out if they are an admitted patient of the hospital or if they're just there under observation. Has anyone ever heard these terms before?
Yeah.
What this means is, so several years ago, Medicare was seeing that the hospitals were treating people over and over again for the same thing. Mr. Smith goes to the hospital, to the emergency department, he's dehydrated. 2 weeks later, Mr. Smith goes back to the hospital, the emergency department, he's dehydrated. Medicare said, hospitals, if you keep treating a person for the same thing over and over, we're going to cut your reimbursement. You're not going to be reimbursed for that second treatment within 30 days, and we may even take money away. So the hospitals, in their infinite attempt to collect profits, the hospitals decided that they would create a little loophole called observation status. So in this case, we're talking about Sally Smith. If Sally Smith is in the hospital under observation, let's say she's there for 2 nights under observation, she's not technically an admitted patient of the hospital. If Sally Smith needs to go to a rehabilitation center like we just talked about, the rehab stay is not going to be covered by Medicare. If somebody is in observation status in the hospital, Medicare will not pay for the skilled nursing and rehabilitation stay. That is why it is important for your loved one, if God forbid they're in the hospital, for them to be in the hospital 3 midnights. 3 midnights as an admitted patient. 3 midnights as an admitted patient. Because you don't want to get to the rehab center and have to pay a month in advance because Medicare is not covering it. Nobody wants that. This is why we have these discussions. I want you to plan ahead. There's a seat up front, young lady, if you'd like. Is everybody comfortable with that observation versus admitted? This is critical because the hospitals, you can even be in the hospital for 3 days and under observation. And they're doing that because if you were never an admitted patient, they can treat you again within 30 days. They can treat you again within 30 days.
Or they release you at 10 o'clock at night so you don't hit the midnight.
We're going to talk about that. We're going to talk about that because these are things that everyone should be aware of. How are you today? Welcome. I'm Mark. So we're about right on the back of the second page. Right there. So who pays for Sally's skilled nursing care when Medicare runs out? What about Sally's supplemental health insurance policy? No. Does Sally have long-term care insurance? No. In this case, this point of the case study, we didn't give her long-term care insurance. Can she get it now? No. long-term care insurance requires medical underwriting, and so they've got to deem you medically acceptable to receive long-term care insurance. If you already have an issue, God bless you.
Take your chin.
If you already have an issue, you're not likely to qualify. Can Sally qualify for Medicaid? She's 18, she's over 18, blind or disabled. She must meet medical eligibility requirement as she requires nursing home level of care. And she must have assets under $2,500, not including her house. So she must be at the poverty level, and she can't sign over her assets. We're going to talk about that in a minute. She can't just sign over her assets to her children and qualify for Medicaid. Medicaid has a 5-year look back. They look back 5 years. This is why, again, why we have conversations like this, because when you plan and know these things in advance, you can plan for them and protect yourself or your loved one. In this case, Sally's a widow of a wartime veteran. She could be eligible for a wartime pension. Is anybody here a veteran or spouse of a veteran? Spouse or veteran? Spouse? During a wartime.
Yes.
Okay, so there is a wartime benefit for wartime veterans and their surviving spouses. Many veterans and their families don't know about it. It's called Veterans Aid and Attendance. And the minimum criteria is that the veteran served at least 90 consecutive days, that they were active duty at least 1 day during a war period. It doesn't mean they were forward serving, only that they were active duty, and that they were other than dishonorably discharged. And then what they do is they look at your assets, not counting your house. Your assets have to be around under $130,000. So if you have more than one house, your second house is considered an asset. If you have just one that you're living in, that's not considered an asset. So there could be, in this case, if Sally needs care, there could be a benefit that she could qualify for, which pays for non-medical home care or long-term care. Can she qualify for Medicaid? I've just brought this slide up again to talk about it. Assets under $2,500. All assets are at risk, including cash, retirement accounts, life insurance policies, stocks, savings bonds. You can plan ahead to protect and preserve your assets, but they have a 5-year look-back rule. For those of you who heard me say that I grew up in a nursing home environment, what used to happen in the nursing home would be, if I want to check into the nursing home tomorrow, I sign my assets over to my son today. And tomorrow I check in, and once I'm there for 30 days, they apply for Medicaid for me. But Medicaid said, wait a minute, people are abusing the system. Some people who even have money are taking advantage of Medicaid. So Medicaid said, well, let's look back 1 year now. And then they said, no, let's look back 3 years, but now it's 5 years. Do any of you know that you're going to be sick within the next 5 years? Plan ahead to preserve your assets. There's legal, moral, and ethical ways to preserve your assets, protect yourself and your family. If not, God forbid, you have to go into a long-term setting, you have to spend down and spend money and get rid of your assets before you can qualify. And you didn't work hard all your life to give away all your stuff to provide care for yourself. So when you preserve and plan ahead, you can do so. So in this case, Sally's assets are at risk. She should speak with an elder law attorney. 5-year look back. Those things are important. So how does advocacy work? Because I want to talk about advocacy. What is her viewpoint? Right now, Sally is not in the mind where she can make conscious decisions to benefit herself. Clearly, based on the case study, she was found wandering. She was dehydrated. She wasn't taking care of herself properly with her hygiene and so on. So she can't make decisions for her own best interest. So advocacy is up to someone else. But advocacy advocacy is critical when a person can't understand the situation. That's why, again, while we are healthy and young and of our right minds, let's please have a discussion with our family on how we would want to be treated. Let's put it on paper and protect ourselves so these types of things don't happen. But who is Sally's advocate? The family can work as her voice, being her advocate, or they can hire a professional advocate. Again, if you want a loved one or a good friend to be your advocate, appoint that person, but discuss your wishes with them in advance and then put everything on paper. Families should agree on the plan of care. Again, I keep making the point, but I'm making it because it's critical. My mother last year on Valentine's Day was having elective open heart surgery. So before that, my brother and I sat down with my mother and discussed what her wishes are, how she would want to be treated, what if something goes wrong with the operation, and so on. We had the discussion in advance and we had a plan. My brother is her advocate and I'm the backup. So when you plan for those things, when those things occur, if God forbid they do, you can get right on the best, working toward the best outcomes. You unburden your family. They don't have to fight over or get their egos involved or anything like that. Not that your children or loved ones have egos or anything, but I've heard about that happening, right? So, you decide in advance, you decide on who's going to be the advocate, the primary spokesperson, who's going to be the backup, you put the wishes on paper. And this means that all caregivers should know what questions need to be asked and what treatments to expect. If the family disagrees over something, it's twice as hard to get the hospital staff to move toward providing the best care. I want to convey that, how important that is. So what I've done is, in the back of your packet, which I've clipped together, you will find a list of hospital terminology. You'll find a list of hospital terminology. You'll also find a list of disease organizations with their websites and their phone numbers. Why did I give this to you? I gave this to you for these points. If your loved one goes to the hospital presenting with signs of dementia and you don't understand dementia fully, or what questions to ask of the practitioners, or what practitioners should be involved in the hospital, you can go to an organization that specializes in dementia. An organization like the Alzheimer's Association or something like that specializes in dementia, and you can get a list of questions to prepare you to provide the best outcome for this person laying in the hospital bed. Does everybody understand that? Don't listen to Betty at the grocery store. Don't listen to Sally from church. Go to a trusted resource to find out what questions you should ask and how to ask the right questions. If you can't go to one of those disease organizations, you can go to the National Institutes of Health, NIH. And I've listed that website at the bottom of that disease organization page. NIH has different categories of health information which can help you make an informed, educated decision. Is everybody okay with that? I put a list together of hospital terminology because hospitals are different now than they used to be. It used to be when we would go to the hospital, our doctor could come and see us at the hospital. For those younger ones in the back, your family physician used to come see you in the hospital. They don't do that anymore, gang. The persons that work in the hospital, the physicians in the hospital, are called hospitalists. And if they see you in intensive care, they're called intensivists. And if they see you in critical care, they're called criticalists. So I put together a list of hospital terminology. Those physicians have probably never met you before. They may not know your health conditions. They may not know your health history, what medications you're taking, or anything. That's why it's important to have that information with you, or in a place that can be carried away if, God forbid, something happens while you're at home. But if, God forbid, something happens while you're out, one of the things that they're recognizing now is that you can put your information on a thumb drive, a digital drive, and carry that with you on your person, and mark it medical. And you can have your medications on there and your documents, and that way it's accessible and you can carry it with you.
But once you're in the hospital, or once you have been admitted, and you make sure that you have been admitted, can't your GP come to see you if they are allowed? There's
They're
something
admitted, if they're,
Privileges.
practicing
If they have privileges, yes.
With that hospital.
Typically, most of your primary care physicians will not practice in the hospital now at all.
Right.
It's very, very rare that your physician will practice in the hospital unless they are a specialist, like a heart surgeon that works out of the hospital but also has a community office. It's rare. It's because of the way the healthcare model is set up and the reimbursements. It's sad but true that
So the people who are seeing you for the very first time have no idea about you at all.
yes, ma'am, and that's why I do presentations like this, so everybody can make themselves aware and prepare.
Unless it's an HMO that has privileges
Yes.
at that hospital. For
Yes.
example, Kaiser Permanente.
Like some of your Kaiser physicians
Right.
practice in certain hospitals.
Right,
But in most cases, your primary physician will not see
Right.
you in the hospital. So that person seeing you for the first time in your health situation, in this case, let's talk about Sally. That person seeing Sally the first time may not have ever met her before, don't know her health history, they don't know what medications, what treatments. So it's important to have all this documentation in place
the other thing. it's
to
not
be the
necess-
best advocate for
It's
her.
not the same hospitalist every day.
Yes, that's correct.
Okay.
It's a hospitalist
It's
group.
Mondays.
It's an organization.
Tuesdays.
It is.
Yes, it is.
It's not a random like hospital. It's typically like the Adventist hospitals they work with one group of hospitalists, and they hire.
So you're in the hospital
Yes.
and someone comes to see you, and it may be a different person each and every day?
Yes.
Yes, ma'am.
That's just the hospitalist. There's also different nurses.
Right.
There's also different physical therapists. So
Yes.
keep a diary. Okay?
That's why understanding advocacy is so critical now.
When you say, excuse me, when
Yes,
you
ma'am.
say keep a diary, I know what a diary is, I know what you're talking about.
Okay.
But if you're in the hospital and you're sick, how you gonna keep a diary?
Your
That's what your
advocate.
advocate
That's why
should
you
do.
need an advocate.
If you are not capable of keeping track of the situation, your advocate should be capable. You should assign someone who's capable of keeping track of the situation and can understand what's going on.
Right. So advocacy isn't just for dementia. Okay?
No,
It's for
It's
general
everything.
hospitalization.
If I went in
If
for
you're
a
admitted.
broken leg, I would have somebody, my advocate, taking the notes.
yes,
Okay, in terms of Dr. So-and-so is here at 9 o'clock and said this should be done today, this is the health plan for today. Make sure that it occurs during the day. If the tests that are supposed to be run aren't run, cause that's different contractors, okay? It's
So
as
if,
confusing as it
if
can
you
be.
have an advocate there, that person can question the medication and stuff that you're given, or being given?
Yes.
yes,
Yes, yes, because
Yes.
you would. If you had a broken leg and they came in and said, we're going to do surgery and cut it off, you'd have some questions, right? Well, if you're unconscious,
You can't question.
that's right.
Or if you're on
Yes.
so much pain medication,
Right.
you
Yeah,
don't know
making
whether it's
sense on
today or
what's going on.
yesterday.
Right.
that's why it is important to have these conversations well in advance of getting sick. Yes, ma'am.
Yeah.
Isn't there what an advanced directive is for?
yes, the advance directive spells out what your wishes are, but if A, God forbid, you don't have them with you when you're in the hospital, and B, we talked to earlier, your advance directive.
Or your most form, or anything. But see, those.
Your advance directive is a form which spells out what your wishes are, right?
But it might not,
Right.
but it's very much focused on end of life types of events. It's not focused on, the other types of things.
Right, that's why,
For
like,
example, the type of
You mentioned
anesthetic.
like if we unconscious and can't talk, it might not be in the light, but you ain't in a position to make any decision.
Exactly.
but even if you have the documents in place, if there's no one in the hospital to advocate for you and you're not in the capacity to speak for yourself, your rights may not be protected.
That's right.
Because they may not have access to those forms, you may not have carried them with you, they may not have been conveyed to the medical staff in the hospital. And that's why your advocate has to be on top of all of these things if you cannot speak for yourself.
It's really.
When, I'll give you an example. I spoke earlier that my mother had open heart surgery in February. When we were in the hospital, when she was having the surgery, my brother and I and my sister-in-law were in the waiting area, and a social worker came in and gave us this thick packet of information, thicker than the packet I gave you, and said, here's the resources for when she's ready to leave the hospital. If I haven't been in healthcare, I would have been like, where do I start? How do you know? Where do I go? And because hospitals now also use electronic medical records. It used to be you could actually pick up the physical chart on the person's door or clipped on their bed. You could pick up the chart and flip through and see what treatments, what medications they've had, and so on. You don't have access to that anymore.
That-
It's all
that's just-
computerized. Almost all the hospitals use electronic medical records. So you, as the advocate or the family member, may not see everything that's going on. So it's important to understand who the staff is in the hospital, what each procedure is that each person is going to be carrying out, that you keep track of it, as this young lady indicated, and that you understand what the purpose of the treatment is. Because sometimes they just want to do treatment. I don't mean to be cynical, but sometimes they just want to do treatments because they can bill for it. Sad. You had a question over here? I'm sorry?
What you need it or not?
Oh, yeah, that's.
I would be willing to say that probably 50% of medical treatments that are billed for were unnecessary.
So you really need a health advocate there,
Yes, ma'am.
and someone who knows what's going on.
Yes, ma'am.
That is
And it's someone that, most importantly, someone that understands what your wishes are. That's why we have these discussions. Someone that understands your wishes and how you would want them carried out.
And sometimes there are occasions where they have people who are burning, interns and whatnot.
And they
They
don't know.
wanna do a test that you may not need, but they need the experience of the test.
But don't you have to get consent?
If you're out, you can't get consent for anything.
That's why it's important to have a good advocate and someone who understands what your wishes are. You had a question, young?
I was gonna say that, you also have to be careful that the doctor or whoever it is who's treating you is on that staff, cause they could be contractors from somewhere else, and they will bill you, and your insurance may not pay it.
How does that happen?
So,
It happens, it's happened to my husband.
yes, it does. The hospitalist group is going to bill you separately from the hospital.
Right.
Yes. If an intensivist comes in and does a scan, the intensivist who did the scan is gonna bill you separately through the hospital. That's what she's saying. That's why it's so critical in this day and age to understand the healthcare system and what's going on with it and how to protect your loved one. And that's, yes, I don't mean to scare you, dear, but
I'm-
this
I'm
is
not-
happening every day.
I'm not afraid, I'm
Just cute.
disturbed.
Incredulous, yes.
because I'm planning to have an orthopedic doctor look at my knee, cause I probably will need a knee replacement. But this is just unbelievable, all the stuff that you have to do and know before you set foot in the hospital.
Yeah.
Yes, ma'am. It's a different world.
It's
And this is
different.
why I come out, I wanna share this information, because if I can help one of you, hopefully the information helps all of you, but if I can at least help one of you not have to go through this, then that's great.
And
But
see,
everybody in this room, every single person in this room can benefit from this information,
At some point, we'll need to have this information knowledge-wise.
always.
but it changes
be the
every
best.
year. It changes because Medicaid and Medicare laws change, okay? The companies, I took someone to a nursing home 2 or 3 weeks ago, okay? Where there was supposed to be, what's that, hospice care, okay? I called, cause I didn't hear from the hospice people, I called them the morning that I was going, and they said their company had been sold last night.
Oh,
Oh my Lord.
And the person had been transported at 10 o'clock, okay?
Before the 12 o'clock?
Uh-huh. And I knew that but they had been in the hospitals. But I knew there wouldn't be hospice there at 10 o'clock at night. I wouldn't have been there even if I'd been hospice. But I certainly expected them there at 8 or 9 o'clock the next morning, since they were giving care, okay? I called it. So I had to work through Kaiser, who discharged them, to get a hospice. We had to start over from which hospice do we use, and there's lots of them. And had to get somebody there before treatments of this person could happen. And it was more than 24 hours before they had their first treatment, including water and food. Okay.
They couldn't get anything?
Oh, the nursing home was very happy to give that, but this
They were
person didn't want that. That's why they wanted hospice. They wanted to be administered to the hospice. It was in all their legal documents for years and years. Everybody knew.
So if
But
you
I
have,
couldn't get that done for
if
them.
you have legal documents, it's best to check them frequently.
But you're not gonna, how many times are you gonna think a company's gonna change overnight?
Well, yeah. Well,
Yeah, I
you-
mean, it was the worst, it was the worst
Oh, no,
time.
they're not gonna tell you because they wanna bill you.
well, no,
Oh, no, they don't. No, they just, the
your-
person,
your wishes
when he
aren't-
didn't know it.
your legal documents aren't gonna spell out the name of the hospice agency or anything.
Right.
Understood.
Only that's the type of
This is
treatment
what you
you would
want
wish
done.
in this situation.
Right.
Or what you don't want done.
Right. So,
Yeah.
an effective advocate does the following: asks questions and observes. They learn to understand the importance of remaining emotionally steady and polite. They acknowledge that there will be stress and uncertainty. Here's why this is important. Because the medical staff are people. And if every time they go into Sally Smith's room, they're getting barked at by Sally Smith's family members. Sit her up, lay her down, stand her up, walk her around, change her every 15 minutes. And they bark every time they walk in the room. The hospital staff is going to stay as far away as they possibly can until they have to administer a medication or there's a situation. So the best thing to do is to make that staff part of your team to help Sally Smith rehabilitate better for better outcomes. So you say to the nurse, "Nurse, is this the most comfortable we can make Sally? Should we sit her up or whatever?" You engage them and ask, "What's the next phase of the treatment? What are we expecting next?" And you engage them and ask the right questions and find out who each person is and ask the right questions. Get them as part of your team. That's what a good advocate does. Is they're not interested in satisfying their ego. They're interested, in this case, the best outcome for Sally Smith. That's what the advocate does. As you just described, you were interested in the best outcome for your friend, the person whom you took to the skilled nursing center. So you're asking the right questions. You're driving the right sorry?
Who pays for hospice? Is that another bill?
Hospice is covered under Medicare,
Medicare.
under certain situations. Under Medicare, hospice provides more treatment than if you were to go home with home health. But in order to receive hospice care, I'm going to cover this in a few slides, but I'd like to answer the question now since it was brought up. In order to qualify for hospice care, you have to have a diagnosis that is considered terminal, but it does not mean that death is imminent. It's only that the diagnosis is considered terminal. So hospice is a form of treatment. Hospice is not a place. It's a form of medical treatment that's more geared toward comfort and palliative measures and pain reduction and optimizing, getting the optimal life for that person based on where they are. A person can be on hospice for years. They have to recertify every 6 months. And they can go off of hospice. Yes, ma'am.
So is hospice there 24 hours a day?
No.
Oh.
In
So what
in
happens
certain,
if they're not there?
I'm sorry.
What happens if they're not there? Then the nursing home takes over?
In certain, there's different situations, but if you're in a inpatient hospice environment, it's 24 hours. If you're in a skilled nursing home that has a hospice agency come in and provide care, it's 24 hours. If you're receiving hospice care at home, it may not be 24 hours. Every situation is based on what the rules that, and hospice has rules of engagement too because they're a Medicare agency, covered agency.
Isn't this true, Art? Even in skilled nursing homes, I think the Medicare standard is 1 observation every 4 hours. There has to be at least 1 nursing observation every 4 hours, isn't it? It used to be 2 and now it's 4.
I don't know exactly what that standard is because it's a moving target.
Yes, it is. Yeah.
It has kept changing.
Yeah, and I think right now it's 1 every 4 hours. So just because you have a loved one in a nursing home, and the fact that there are staff present 24 hours a day, doesn't mean they personally are being observed more than once every 4 hours or once every 2 hours. Even 2 hours is, it's like, if you have a 3-year-old, you're not going to leave them alone for 3 hours, right? It's
Right.
just, and that's one of the big issues. And they have like 16 patients that they're trying to take care of.
That's one of the reasons that I want to come out and have discussions like this because your eyes are open. You're hearing things. All of you, I'm seeing the way you're responding. You're hearing things that you may not have ever heard before.
Never heard before.
And you have to plan for it. If not, the system is going to be operated the same way whether you want it to or not. But if you have a good advocate, or if you're a good advocate for that person, you can get better outcomes working the system properly. Communication, patience and skill. It's easy to lose your temper. It's easy to say things that are likely to bring anger back to the patient. You want to make sure that the patient, in this case Sally Smith, the person we did the case study for, you want to make sure she's comfortable and getting the best treatment. It's not about ego or who winning and losing. The best outcome for that individual in the bed is what you're aiming for. Avoid confrontation. Remember, Sally can't communicate very well and may get upset at conflict in their environment. One of the worst things you can do, especially if a person is agitated with dementia and they're uncomfortable, and you're in the room arguing with the medical staff, that's very off-putting. So the best thing to do is keep it calm and low-key. If there is something that may be confrontational, think of a nicer way to put it, but also step out of the room so that there's not conflict in the room.
I think another
Underst-
thing
Go ahead.
that I would consider putting in that slide, be prepared to apologize for your loved one's behavior, okay? Because there's a period of time where they don't know what they're doing is wrong, or socially unacceptable, etc., okay? So you need to say, oh, I wish you knew this person like I knew, and they're such a nice this is the illness this isn't them.
The hospital staff is, especially with more and more people getting dementia, the hospital staff is trained to understand working with someone with dementia. Some people are better at it than others. Remember, when your loved one has dementia, your world and their world are different worlds. So what you have to do to effectively work through this process with them is meet them in their world and keep them safe. Meet them in their world. If they say that it's raining out and it's clearly not, okay, it's raining. Well, let's get our umbrella and let's go out if you're going to go out. If they want to carry an umbrella, it's okay. Meet them in their world. Don't try to bring them into your world. So the hospital should understand how to work with this individual, but that's why advocacy is so critical, because the advocate is making the decisions on the treatment, and the healthcare staff is still required to explain to Sally Smith what they're doing and why. And if Sally Smith balks at that, they can just positively redirect Sally and still do the treatment. Okay? So understand how those hospitals work. Understand that form that I gave you, which has all the different hospital terminology.
Are there hospitals that have special floors for dementia or Alzheimer's?
Some do, some don't. Some hospitals in the area, like Holy Cross, has a senior, specifically a senior emergency department. And so they're dealing, and a lot more of the local hospitals are doing that because they're seeing that there's more positive outcomes, and their staff has more intensive training to deal with issues like dementia and things that are more prevalent in seniors. So yes, that's a great point, and that brings up another point I want to make, and I'm glad you brought that up. Many people, when they have these discussions with their family on how they would want to be treated and so on, don't even know what local hospital they would be taken to if, God forbid, there was an emergency. Have any of you ever visited your local hospital to see what treatments they provide and what their specialties are?
But the EMS decides where you go.
Well,
Yeah, where they have
they
space.
do and they don't. They do in as it relates to things like stroke and things like that. And they do as it relates to if there's a number of emergencies that a hospital can't take you.
Right.
But as best as possible, they're going to take you to your local hospital if it's a hospital that's set up to provide the treatments that you might need based on what they're seeing. So finally, yes.
Who pays for the ambulance?
You do.
Well, no, there's a bit of a Medicare benefit.
It is.
but
It's
doesn't
covered.
co- it
It's
doesn't-
covered to it typically the ambulance from, if you need an ambulance to get from the hospital to the rehab, typically it's covered by your insurance. Typically. But don't assume that.
Right.
Don't assume that. Don't assume anything now. Make sure you're protected. Make sure you have the right documents. Make sure you understand if you're getting an ambulance ride, who's covering it. You have the right to ask that. So it's time for the discharge. Things have moved along, and after a few days, the doctor's ready to send Sally to a rehab unit and then later home. What does this mean? Caregivers have to learn quickly what they are and how to choose a good one. Tour appropriate centers unannounced.
Can you get into one unannounced?
Yes. So, the hospital may have a specific center that they like to send everybody to. But that may not be the center that you wish your loved one to go to. And unless your loved one requires a specialized type of treatment like dialysis, which not every skilled nursing center does, or is on a ventilator, which not every skilled nursing center does, other than those specialties, you have the right to choose which skilled nursing center your loved one goes to. So what I recommend is, in this case, if you're Sally's advocate, and she's in the hospital and a couple days before she discharges, the doctor's telling you that they're going to recommend a rehab for Sally, what you do is you go visit the rehabilitation units in your area, and you visit them unannounced, and you ask for a tour. And when you visit these skilled nursing and rehabilitation centers, you use all your senses. What does it smell like? Does the staff engage you? Do they make eye contact? Are they showing you around the whole place? Or are they just showing you this one hallway which looks really shiny? And then, how about this? Look at the way that they're treating the people. So when you go unannounced, you're not going to get the dog and pony show. You're going to get a real picture of what it would be like for your loved one there.
And they will give you a tour.
Yes, ma'am.
Yeah.
Absolutely.
Unannounced,
Absolutely.
just walk in and say, I'd like to have a
Yes,
tour
ma'am.
of the building or
Yes.
everything.
Say, I have a loved one that's discharging from the hospital in a couple of days. They're discharging with this, this, and this, and I'm looking for. I did that with my mother. My mother was certain after her operation for her mitral valve that she was going to go home right after the hospital. I said, Mom, you're having respiratory issues. You're not going right home. You're going to go to a rehab. I said, and I've already scouted out the rehab. I got a tour of it, and I learned that they had a specific respiratory specialty. And I talked to the respiratory therapist before. And so when we were at the hospital, I said, this is where she's discharging to. Because that's where she's going to get the best outcome. You absolutely have the right, unless there are certain situations. Like this young lady talked about Kaiser. Kaiser has certain facilities that are Kaiser skilled nursing, they support Kaiser. So you're going to go to one of the Kaiser facilities. So if you're going to go to a Kaiser facility and you're with Kaiser, tour 2 or 3 of the Kaiser centers in your area. But you have the right to decide.
But there's only 4 of them in the 2-county area.
Right. Now,
Sibley, what is it? Home Pro, Washington
No,
Hospice.
those are skilled nursing,
What are you talking about?
skilled nursing.
so once the patient is ready to move, a discharge planner, usually a social worker or a discharge nurse, is going to go through the instructions with you. You make sure that there's a written set of instructions. You make sure the discharge is done in a timely fashion. You described earlier, your friend was discharged at 10 o'clock at night. You have the right to dispute that and order them not to discharge your loved one at 10 o'clock at night. And here's why. Let's say Sally, when she was in the hospital, she's given medication A, B, and C. And if on a Friday night, the hospital wants to discharge Sally at 10 o'clock at night to the skilled nursing center, Sally's evening medications aren't going to be at that skilled nursing center. In the morning, if Sally has to take medications in the morning, they're not going to be at that skilled nursing center. They're probably not going to be there until the midday or afternoon. So it's possible your loved one may not get the right medications or treatments if they're discharged at night to a skilled nursing center. So you have the right to say, A, I would like an orderly discharge, which means every step of the next phase of care is aligned and in place. If the medications aren't at the skilled nursing center when she goes, then you have the right to ask the hospital to send the medications with her. Again, this is why we have these discussions, because I want you to be prepared to be an advocate if, God forbid, something like this happens. Everything should have written instructions. The medications that she's supposed to take, written prescriptions. The treatment, the medical treatments that that they're requiring for wound care, in this case because she had wounds, for physical therapy, occupational therapy, those orders all have to be written when she goes to the skilled nursing center. That's called an orderly discharge. You can request that the hospital not discharge your loved one at 10 p.m. You can request that and say you will discharge them tomorrow morning.
Well, do they send it in the morning? I mean, who's to say that they don't, when they get it? Or
You can,
get it?
if it gives you more time to coordinate with the skilled nursing center, you can have the hospital, if they give you the written prescriptions at night, the skilled nursing center can order them at night from their pharmacy and have it delivered in the morning. And it could be there in the morning. That's why proper advocacy and proper planning can help with a lot of these issues. And again, it's about the best outcome for your loved one. It's not about ego or anything else, but it's about the best outcome.
One of the things they'll say to you is, we can't guarantee a bed tomorrow.
What does that,
That's fine.
what does that mean?
They don't wanna take them at night.
Skilled nursing home.
Also, they wanna make sure you're out of there before 12 at night.
That's fine.
But what they'll
So
say
they'll
is that
say
if
they
They
can't
said that
guarantee
there's no
a bed.
bed for you. What do you do?
the hospital can't discharge you unless there's a bed. So it becomes their problem, becomes the hospital's problem, not your problem.
But you mandate that you do not wanna be discharged at 10 o'clock.
I don't recommend it.
Yes.
I mean, the only reason
I
I
do
went
not.
through with it is
It's not,
you know,
you don't wanna go to a skilled nursing center in the middle of the night.
the only reason.
They're on a skeleton staff.
Right.
They don't wanna just, it's hard for them to check in a new resident into a skilled nursing center at 10 o'clock at night.
What about weekends? Cause I've
Same.
heard same thing, you wanna go the first of the week, if possible.
They're used to a lot of weekend admissions because the hospitals wanna clear as many beds as they can for the weekend. So,
But you still have a skeleton crew?
usually,
And people that don't show
Don't
up.
get sick.
And people,
Don't get sick.
people that call in
Don't get sick,
sick.
period.
so, here's what you would qualify for if you're going to a skilled nursing or rehab. You qualify for skilled nursing needs, which is anything that a physician writes a medical order for, which could be wound care, medication monitoring, or IV medication, intravenous medication, physical, occupational therapy, speech therapy, respiratory therapy. Okay? Remember, to qualify for Medicare coverage for your skilled nursing stay, you need to have a minimum of 3 midnights in the stay as an admitted patient in the hospital, yes? You could qualify for home health care. If you do not need to go to a skilled nursing or rehab, you could qualify for an agency to come and provide that kind of skilled nursing care in your home, covered by your Medicare. And again, that's everything that a physician would write an order for. You could qualify under Medicare for a physician to come and see you at home. If it takes a considerable effort to get you out of your home, or it's not safe to take you from your home, then you could qualify under Medicare for a physician to see you at home. Which, that's what I just touched on. Hospice care. To receive hospice care, you must have a terminal diagnosis. A physician has to determine that, to the best of their ability, that a person has a terminal illness, and every 6 months it has to be recertified. So hospice care could include medication management, bathing and personal care, wound care, meal support, safety monitoring, spiritual and family emotional support. And a lot of that's covered, typically hospice in the home or hospice inpatient is covered by Medicare. But there's certain rules that they have to follow based on certain facilities and so on. I'm a believer in hospice care. My father was on hospice the last 3 months of his life. He was living with me. He was diagnosed with lung cancer. He didn't want to do anything aggressive. So they worked with him on his comfort, helping him live his optimal life for the last of his days. Monitoring his pain levels, his comfort, and engaging him and keeping him as comfortable as possible. He didn't want anything aggressive, any chemo or anything like that. Okay? But if person is getting chemo or something like that, they can receive some degree of palliative care under a hospice benefit, even if they're getting chemotherapy.
What is palliative?
Palliative is just, it's more, comfort measures. It's not invasive. It's not, strict medical treatments. It's more comfort, more, movement, moving you around, and pain management with painkillers and things like that, oxy or God forbid morphine or something like that.
And there's, because I do it, there's spiritual and family emotional support with hospice and with palliative care. It's a matter of helping the person get through it, helping the family get through it.
Yep,
It's all the emotional and spiritual and holistic stuff.
absolutely.
It's the whole kit and caboodle beyond the medical.
And what is it called?
Palliative care or spiritual care with hospice.
Mhm.
It's different, but it's the same, because you're
Yes.
dealing with helping the person know that they're loved, helping the person know that they're cared for, helping the family cope.
And it's not so much treating the disease or ailment.
You're dealing with
Right.
what's going on up here.
Right.
You're dealing with the person.
Mhm.
It's looking more at the whole person versus the specific
Mm. And,
treatment
well,
of illness.
excuse me? Well, while I'm on that, I do chaplaincy in hospitals too, stuff, and this is so helpful, because half the stuff that you're talking about with advocacy and stuff, people show up and they have nobody,
Right.
and they have no advocate, and you have to work double, triple time to help them understand the system and not get used and abused, and how the family to cope so that because they all feel like screaming most of the time, how to help them be calm and everything. If they know this ahead of time, it's so helpful, so, bravo.
Thank you.
I'm trying to turn it off.
That's okay. The button on the side.
It doesn't.
That's okay.
There it goes. It's off.
So,
Okay.
a person could also receive home care, non-medical home care in the home. Typically, these non-medical home care could be covered under Medicaid or Medicaid waiver. It's not covered by medical insurance because it's non-medical care, but it could be a person who can come in and help with bathing, dressing, helping as a standby assist. It could be a person that comes in and provides personal care by a certified nursing assistant.
Can I just say something real quick about the waiver? Because this is what I deal with.
Yes.
The waiver has a outrageous wait list.
Yes.
Sorry, registry, as
Yes.
they call it.
Oh, yes, the registry.
And they're telling people 7 to 10 years before your name even gets looked at.
So,
But
can
still
I-
put your name on the registry in case.
Can I ask again? I asked you earlier, how many of you know if you're going to be sick within the next 5 years? How many of you know if you're going to need the registry within the next 7 or 8 years? And the registry is a scoring system, is it not now? Based on your needs. So if you have very few needs, you're not going to score high enough to qualify. They'll score someone who scores higher, who has a greater need, is going to get the Medicaid waiver benefit before you.
And just so everyone knows, they're kind of reprioritizing it. There's some new regulations about to come out, supposedly, they keep saying, but to try and ease, it's 20,000 people long, so. It's,
You know the only way the list gets shorter is people die or people get on.
but they don't know,
I
that's
put
what
my
they're trying to
aunt
find
on
out.
the list 7 years ago,
Uh-huh.
and they just sent us a letter to say that she was pulled off of the list. So, and she's 97, so it took them 7 years. So I don't even know if she's gonna be eligible.
Yeah, we can talk.
Wait a minute, you said they took her off the list.
They took her,
Why they take her
no,
off?
because she's guess, eligible to apply now. It's,
Oh, I thought you meant they just took her off period.
I didn't even understand what it was, but somebody told me to apply for it, so I just applied for it, to apply for it. And then 7 years later,
So
they
she's
sent,
off the
they sent
waiting
me a
list,
letter.
is that what you're saying?
Yeah, now she's eligible to apply, she's eligible for them to say yes or no, she can be in the program.
It's all about planning. But the best thing you can do is work to keep yourself and your loved ones healthy.
Yes.
See, the healthcare model in our system,
Yes.
the healthcare model is not designed to keep you healthy, it's designed to fix you when you're broken.
Yep. And then when there's nothing left they can do to help the brokenness, then it's like a candy bar at the door.
Right.
Oh.
So, under home care, you could also have a med tech come and administer medications. You could qualify for, under your medical insurance, durable medical equipment, things like hospital beds, wheelchairs, walkers, Hoyer lifts, things like that.
But your doctor has to order those, right?
Yes, that's correct. All these, as the young lady indicated, have to be ordered by a physician. And typically, if you're in a skilled nursing center, they will order whatever you need to get home.
To get home or go home?
To go home, once you're ready to go home, if you need a hospital bed, or if you're under hospice, the hospice will order it. You could need a geriatric care manager. They're not even called geriatric care managers anymore, but I left the title. They're actually, the organization is now called Aging Life Care Managers. But basically what they do is they can, if the family doesn't understand the system, you can hire this type of person that can help you
The walk is.
ease the process and walk through it, yes. Okay?
Oh,
And then a person could qualify for assisted living.
Can I say one more thing about that? Sorry.
Please.
Please check out OHCQ. They are the
Yes.
ones that license all assisted livings.
OHCQ?
OHCQ, if you are Google savvy, it's the
Office
first.
of Healthcare Quality,
Okay.
Yep. Their headquarters are actually right in Columbia,
yes.
but
I thought they were in Baltimore and Catonsville.
so they moved.
Oh, did they?
Yeah. So they license all the assisted livings, but just a little FYI for individuals. So when you get licensed as an ALU, if you go to Office of Healthcare Quality, they have a nice little license directory. You can type in by name,
Any type of
address, something like that.
County, it's separated by
County,
county.
yeah.
To see whether that's
To see if it's
licensed.
licensed. The thing that you want to ask is if they say, let's just say ABC assisted living. If they say, okay, and they may be licensed, but they could have 5 other homes that may not. So you really want to check to make sure if every home that they have is licensed, and ask to see the license, because it is issued by OHCQ or call OHCQ, and they will give you, yes, it's licensed, no, it's licensed.
Is that a permanent license or, annual license or what?
It's,
You must have to
it's
update.
annual,
not-
it's
yeah.
annual, they're surveyed every year typically. And any assisted living, it used to be in Maryland, there was all sorts of different categories. There was domiciliary care, there was, respite stay, there was all sorts of different categories. And what they did is they rolled everybody under one category, assisted living. So whether you have 1 bed in your Betty's Home Care or 1,000 beds in your Sunrise Senior Living, you're all licensed the same way, through the same licensure. And Office of Healthcare Quality oversees healthcare licensing of every variety in the state of Maryland. So Office of Healthcare Quality, you can go to their website and they have a little radio button that says Licensee Directory. You hit that button and it takes you to, you can see who the licensed adult daycares, the licensed walk-in health clinics, the licensed hospitals, the licensed assisted livings. And you can even print the list by county, or you can just print out the county that you need, or whatever. And it typically with the assisted living, it tells you how many beds they have, whether they have 1 bed or 1,000. It tells you if they take waiver. And typically that list is updated every month. So it should be up to date each month.
That's the also place where you can find out the results of their last audit, correct?
You can, there's a different radio button where you can look at survey results. And you can also talk to the ombudsman. Each county has an ombudsman who deals with health issues. And if you talk to an ombudsman and they say that ABC Healthcare Center has 50 outstanding issues, you may not want to send your loved one there.
How do you find the ombudsman?
Go to the department.
Look at
name.
You look under ombudsman in each county.
Each county has one.
Yes.
So you have to have a job of going through, this is the
Senior,
job.
senior
This is the
social-
job.
This is-
Senior social services.
So then,
Social
Senior
services,
social
family,
services.
social
The Office of
services.
Aging, that's what it's.
So
Office of Aging.
this is the reason I do a program like this, is because I want to bring this to everyone's attention. And again, we presented Sally Smith through a case study, all fictitious information regarding this individual, not a real person. That's just a stock picture we took from the internet. So, what questions do you have that we can answer in a few minutes? Yes, ma'am.
the system that you have shown us,
Yes,
is
ma'am.
that nationwide? Is that the system that most hospital facilities and whatever uses now?
Yes, ma'am. Most hospitals use hospitalists. I mean, unless you're in a small town, but most hospitals in major metropolis areas,
That's the system.
that's the system. There's hospitalists, there's intensivists, and it's your primary physicians. It's all about the money. So, I don't mean to be cynical when I say that,
You're
but
honest
sadly,
about the fact that it is about, we recognize the fact that just about everything happens nowadays is about money.
but that's why I want you to prepare yourself and your loved ones, have these discussions, plan and prepare and protect yourselves.
Do you have this information where a family member could purchase? Because I can't remember to tell my daughter or my son, my grandchildren, all this information that we've gathered today. How do you get this information to people who are not able to attend one of these seminars?
The Attorney General of Maryland has a fairly good handbook, okay?
What do you call them?
You can see me afterwards, I have it on my phone or something. But it's about nursing homes, okay? And it gives a lot of the terminology over and over again. It tells you what to look for. and
There
everything.
Much
is,
of what he has said here is on that?
Not it, because it doesn't talk about
No,
problems. It gives you.
I've compiled my information from different places. Each county, the Department of Aging, like in Prince George's County, Aging and Family Services has a resource where you can find some of this information, but that's the challenge, is that this information isn't always in the same place. You have to go to 3 or 4 or 5 places
Yeah.
to find this information. I will say this: if you go to our website, rightathome.net,
Right at home?
right at home, the words all spelled out, rightathome.net, there is a brochure which you can download, which is called Right Conversations. It's called Right Conversations. And I don't have a copy with me, I'm sorry. But the Right Conversations can help you have these type of conversations with your loved ones and facilitate the discussion about when to take the keys away, when they shouldn't live alone, you know, when they need more care, and so on. And it can help you have some of those hard conversations.
Well, and then there's also, not regarding, well, kind of sort of regarding advocacy, but if, like some of the programs we were talking about, like OHCQ and Medicaid waiver, if you contact Behavioral Health Administration, Office of Long-Term Services and Supports, they will be able to walk you through, because that's who I work under.
How'd you like to go slowly with that? Behavior?
Oh. Behavioral Health Administration, BHA, Office of Long-Term Services and Supports. And they can get you connected to the local Department of Aging. They can get you, or talk about the overall, how do you get on the registry, or issues or questions you may have about nursing homes or assisted livings. Who pays for it, what does it look like, you know, so you
And
can
this
get that.
is, say that again, BHA,
BHA, yeah.
give me the words.
Behavioral Health Administration.
Thank you.
Who do you work for?
Me? So I work under BHA.
I mean, what agency is that?
So that is it's a state organization that well, they do a lot, but they really work in the mental health side. So
And you can find this online?
yeah.
Just go on to BHA.com or what?
It's BHA. If you just hold on, I have the website. Let's see.
My problem was that I kept thinking mental health. I wasn't thinking long-term health. with you
Yeah, they
guys.
have a long term. I work under them.
Under the long-term.
Long term, yeah. I'm working on it.
But I know they have a,
Yeah, and that's what it traditionally is. If you type, it's BHA dot health dot Maryland, all spelled out, .gov.
DACA? D-A-K-A?
No, .gov,
Here.
Gov.
G-O-V. Ladies, are there any other questions for me?
Well, with people's spirits a little bit, okay? And that is, like any professions anywhere, there are people that chooses as a profession, and thank goodness they do, because we're gonna need more and more of them, right? As all of us begin to need the care too. But like other there are people that shouldn't be in the profession either. And we've all worked with people like that, right? People that do our jobs well and people that just are on for the ride. And so I think it's important to assume the first, okay? And if you see something that's bad, you need to know, once you find out what the hierarchy is, and that's something, Art, you might wanna consider putting in your presentation is, I learned about the hierarchy in a nursing home the wrong way by speaking up to one of the doctors, as opposed to going through the nursing assistant, the nurse, the supervisory nurse, the head of nursing, and then the doctor.
Oh my God.
Yeah,
There's a lot of, the first time we did this presentation, it was 4 hours long.
yeah,
So I've pared it down to where I can do it in an hour without the elder law attorney.
yeah.
And unfortunately, the nurse who put this together with us, she passed. So I had to cut some
Sure.
things
Sure.
to streamline and simplify, but there are, you know,
Right. You have to
the
find
more,
out which
the
way.
more, as this young lady is indicating, the more you can educate and inform yourself, the better you can advocate for yourself or your loved ones. Educate and inform, find out how a system works, find out who's in charge, find out how the procedure works and everything else. Educate yourself, or else the system is gonna work the way the system works. But if you educate and arm yourself, you can work the system in the favor of the person you're advocating for. And that's not gonna shortcut everything else, but I guarantee you, if you go into any nursing home in this area, or any hospital in this area, the people who have family that visit are getting better care and treatment than the people who don't. Sadly.
That's true.
Sadly, because the squeaky wheel gets the grease, so to speak, in a nice way. Yes, ma'am.
the other thing is, I think to always assume because somebody has Alzheimer's or dementia that you shouldn't take their ideas into account is a mistake.
I agree.
That sometimes they say, you know, somebody hurt me. And you say, oh, yeah, well, they're thinking that way. Because they don't have their brains intact
No,
the same way they used to. Check it out.
You have
Check
to
out
investigate.
everything they say. Just because they have some dementia doesn't mean that you shouldn't be aware that they might have that one and they might
Well,
have
we've-
their
we've-
finger on that.
We've seen only too recently in the news horrible things that happen to people while they're, you know.
Is there a group? Let me see how I wanna ask this. Since this is a group of learning, is there a regular group that people could get together and discuss things that are happening, things that has happened, things to be aware of? Do you know if PJ or if Greenbelt or anything is happening that we could come on, this is frightening. It really is.
I don't mean it to be frightening, it's more, it's meant.
It's frightening not to know, is what I'm saying.
Yes.
And that's
So-
what I'm saying, maybe we could do some type of every 2 months or whatever, because if you don't know, you're gonna be taken advantage of.
Yes, there is a program.
You could be.
It meets on the second Tuesday of the month or the first Tuesday of the month.
So we have the Memory Cafe, which is,
Wednesdays.
those that are affected by, the form of dementia, and they have to pre-register and go through a screening process.
But if you don't have
And if you
dementia
don't have
yet,
it, if you're a caregiver or looking for caregiving support, we also have a group for that meets on
Wednesday nights at 6
Wednesday
o'clock.
nights at 6 to 7:15 in the community center.
you remember,
Right,
I run them sometimes.
yeah.
And,
Is your name Pat?
Huh?
Are you Pat?
Yeah,
Oh, I met you.
yes, you did.
it's
also, you're
interesting.
welcome to take my business card, any of you, which is over there on the table. And if you have questions, if you ever go through the process, just call me, I'm happy to help.
I'm not trying to influence you in any kind of way, maybe. This would be something really great on some type of recording system for families. Like I said, my advocate doesn't live in the States. My grandson has just like me, no concept of this. And I would be willing to purchase something of this nature to give to my daughter-in-law, because she's gonna be my advocate, so that she'd have an idea of what she's getting herself into when she comes to see about me. So that
We
would,
can,
for me, that would be a very helpful situation for her, because she has ideas, but when you come and listen to this, you recognize what she's thinking has no concept to what is actually happening.
So
Again,
we-
if you take my business card,
Okay,
I can make sure that if not a recording of this from today,
okay.
another presentation that I do, that you can have a recording of. I wouldn't sell it. I got into healthcare to help people.
Okay.
I
That's
got into
helpful.
healthcare to help
It's
people,
helpful
and I wanna
because
bring good information that's useful.
as we get older, you know, I can remember how to get to the bathroom someday, but you know, it's, what I'm saying is, you're not there yet, but you do recognize that there are things that you once could do, you no longer can.
But the best thing to do is, first, you start with a clear vision of how you want the rest of your life to go,
I've done,
and how you would wanna live, where you would wanna live, how you would wanna be treated if, God forbid, you became sick.
well, I've done.
And then
some.
you look for ways to keep yourself well and improve your situation. And protect yourself with information like that we've shared today. Okay? My wife and I, so I can't tell you my wife's age, I would never do that. I'm 55. I will not tell you her age, she was born in 1970. So we live in a townhouse now, and we're looking for a larger home. But the home we would move into has to be a home that we can age into. So we're looking for a home where the master bedroom and bath, there's at least one on the main level. I can't tell you how many houses I've been into in Prince George's County, in Anne Arundel County, in Montgomery County, where people have a hospital bed in their living room
Right.
and no bathroom on that level. I had a family I talked to 2 years ago, and there were 6 or 7 kids involved. The mom was 92, living alone in a house that had, when you walk in the front door, 6 steps up to the living room level, and on the living room level was the kitchen and the living room. Upstairs, 5 more steps, the bedrooms with bathroom. Downstairs, from the foyer, downstairs, bathroom and a family room. The family could not get together to plan when I could come and see them. I reached out to the son after I hadn't heard from him in a couple of weeks. I said, listen, have you gotten the time for your siblings to get together? He said, well, Mom passed away. I said, oh my God, I'm so sorry to hear that. What happened? She died of complications from a urinary tract infection
She couldn't get to the bathroom.
because they weren't getting her the proper help to get to the bathroom or to change her diapers. He said, share this with as many families as you can. And see, if you don't plan for these things and think these things out in advance, you're at the whim of the system. We're all intelligent people. Let's plan and prepare that we can have better outcomes for ourselves and our loved ones.
And the system doesn't
I
care.
think,
And listen, here's what I say. Plan in advance, put your wishes on paper. When you start to see things for your loved ones that are becoming harder for them to do, get help. And here's one more story I'll leave with you, and then I really have to leave. The story is this. A friend of my mother's was preparing, this is a Jewish holiday, she was preparing for a Jewish holiday a few years ago. She climbed on a step stool to get dishes out of the thing. She lost her balance, falls and breaks her hip. She goes and gets her hip pinned at the hospital. Then she goes to the rehab after a few days. She's in the rehab having a lot of pain. They take her back to the hospital. The hip wasn't pinned well. So she has a hip replacement. So she has her hip replacement surgery. She's in the hospital for a few days, goes back to the rehab, and it takes her a long time to rehabilitate and get home. 4 months between when she fell the first time and when she finally got home. 4 months. She lost a lot of weight. She was weak and frail when she got home. And when she got home, she broke her other hip. If you can have help with the things that are harder for you to do as you get older, you prolong your quality of life and you reduce your risk of that. And people say to me, well, I want to stay independent. I don't want to have someone coming into my house. I tell them that story. This lady was in the hospital and the nursing home for 4 months. That wasn't independent. But if we could have reduced her risk of falling, maybe she would have been able to stay independent. And then she didn't live another year. Because typically the statistics say when someone has a major fall like that, and they're around 80 years old or older, they don't live a year beyond it. That's what the statistics show. So, again, I'm Mark Ash with Right at Home. Thank you all for being so engaging.